Good evening, everyone. Thank you all for joining today. We'll go ahead and get started. I know a couple of other people might join on, uh, as we get started, but just wanted to make sure housekeeping items that everyone has their audio on mute. And then if you have any questions, feel free to chat through the chat function, and then we can kind of answer questions along the way. And then we'll have some time at the end for question and answer. But just wanted to, again, introduce myself of those that maybe don't know me, but I'm Dr. Mehta, board certified in pain management and physical medicine rehab. And so a lot of the patients on this talk are patients of the practice, whether you see myself or you might see one of the other providers. But as we do manage chronic pain and both acute pain. And you might have heard us discuss, spinal cord stimulator and other options for your pain. And so, I just advocate that really appreciate you taking an interest in your care and kind of looking at other options to provide yourself some pain relief. And so, want to applaud yourself for joining today and taking the time today. So thank you for that. Really what the focus of this talk is understanding other options for diabetic neuropathy. And I think we talk about diabetic neuropathy because it's a very common cause of neuropathy, but in general, this treatment can apply to other nerve type conditions, other burning sensations or nerve type pain that you might be experiencing. So hopefully this will kind of give you an understanding of something to discuss with your pain provider. Um, yeah. So a couple, agendas for this talk. And everyone can hear me okay? Can everyone hear me? Okay, perfect. A couple of things that we're going to go over. We're going to understand pain. What is pain, right? What is acute pain? What is chronic pain? Understand how does diabetes actually cause the neuropathy pain that we're feeling? What are some options that we have for pain relief? And then talk about neurostimulation as a treatment option for this condition. So what do we say when we talk about pain? Pain is really any unpleasant sensory or emotional experience, right? And so I think that's important is that pain is not only what you're feeling on your body, it's actually, how you're perceiving that pain. How do you feel emotionally, when you're in that chronic pain? How does your mood change? How does your sleep change? And so that is really a component of why we treat what we treat. And so, you separate the pain really in two buckets. One is a neuropathic pain. So that typical pain is pain that's burning, tingling, shooting down the leg. That's the typical burning sensation that you might be experiencing. Whereas mechanical pain is pain if you have an injury, you fall, you injure your knee, you get bruised. That pain is the mechanical pain. And so you might be experiencing both. You might be experiencing on one day neuropathic pain and on another day mechanical pain. You might experiencing them at the same time. And so, that is our job as a pain specialist is to figure out, what is the pain that you're having at that point and how are we going to treat it in the most conservative way. And so, again, here's just to break up what we just talked about is that mechanical pain is that pain if you cut yourself, you fall, that severe pain that you're getting at that time. And that neuropathic pain is again that burning, tingling sensations that you might feel, from diabetic neuropathy, from a previous back surgery, or just wearing down of those nerves. And so most of, what we're dealing with is chronic pain, right? So not a pain that just happened a day or two ago and now the pain is better. This is pain that you guys have been dealing with for a long time, right? Pain that's been dealing for years. And so those nerves, the body has responded to that and certainly can make it challenging to treat, but certainly there are long-term options of ways to control this pain. And so we know that chronic pain um, is not treated by just one thing, right? We have to really provide a multimodal pain control, and that includes medications that can control inflammation, nerve type pain, physical therapy that can strengthen the muscles to support the structures in your body, and then maybe injections or therapies or surgery therapies that can really reduce the pain episodes or treat the actual compression. And so you know where we kind of are in dealing with chronic pain is using all these therapies together to get you to some goal, and that goal is to be able to function. That goal is to be able to go to the grocery store, play with your grandkids, have a social life, have that kind of function that we're all striving for. And so, breaking it up even further is that, pain can be the whole body, right? Pain can be the upper extremity, the arms, the head, the neck. When we talk about neuropathy, typically it's pain down in the feet, down basically the ankles below. And I have seen some patients with neuropathy conditions that really go from the back down to the legs. And so as diabetes gets worse, as the neuropathy gets worse, it starts at the ankle, feet and ankle, and kind of works its way up. And so, kind of the question that I want you guys to ask yourself as we're going through this talk is, do you feel like you're in one bucket, right? Is your pain more neuropathic, or is your pain more mechanical? The second question I want you to ask yourself, do you feel this pain every day? Or is this some pain that's very sporadic, right? And then the third question to ask yourself, is it localized to a specific area? Do you feel it just in the feet, or do you feel it in the back and all the way down the leg? So, as we're going through this talk, ask yourself that question and see where you fit in. So, we know diabetes, back pain is one of the most common conditions seen by a primary care doctor, but back pain itself, or diabetes itself, is a very common condition, unfortunately, and it's on the rise. And so over 96 million Americans have prediabetes, and they don't even know they have it, right? And so that's checking your blood sugar, that's checking your primary care, blood levels, and making sure you're within range. 20% of the patients that are diabetic do get diabetic neuropathy, right? So that is a pretty significant amount. And so whether you're controlled or not controlled, we know that having diabetes does predispose you to having this pain condition. And so it's very important that if you're not diabetic to, monitor your blood sugars, make sure they're controlled, and that if you are diabetic, to again work on proper diet and exercise so that you can prevent the progression of that neuropathy from getting worse. And so, where does neuropathy start? Like we said, it's more the numbness, the tingling, the neuropathic pain symptoms that patients present with. That nerve damage that happens can be very debilitating. And patients can present with ulcers in the legs. Patients can present with, calloused feet. And so I typically tell all my patients that have diabetes is to regularly visit with your podiatrist so that they can make sure that the wounds look okay and the legs are healing correctly. Because the last thing we want is that wound to get worse and to open, and now you're dealing with an infection. And so if you have diabetes, you should have kind of regular visits with your podiatrist to optimize that care. The foot is important. It's probably one of the most important pieces that we have in our body, aside from our brain. That foot is that foundation. So when you're walking, it's really providing stability for yourself. So if you think that you have neuropathy, you can't feel the ground very well, that tingling is affecting the way you're walking, that's going to affect everything above that joint. It's going to affect your knee, it's going to affect your hip, it's going to affect your back. And so it's very important to, number one, prevent injury, prevent the disease from getting worse, optimizing the care in your feet. But then also, if you have the pain, coming up with ways to treat it so that you can not feel that burning in the feet, so that when you walk, you can function. You can move better. You don't have that loss of balance. And so that's really what we're going to talk about, is how to reduce the pain in those feet so that you can kind of be better functionally. So pain is a vicious cycle, and I'm sure there's some piece of this pie chart that all of you are dealing with, right? It's number one, it's the decreased activity, right? Pain allows us to not move as well, right? And so when we don't move, when we are not active, that can lead to frustration, anger, anxiety, right? And that can lead to dependence on medications to get out of that cycle. The longer we're dealing with pain, the longer it involves changes in the way our brain is functioning, right? The way we sleep, affects our emotion, our stress on relationships. And so, um, that's why we're here. That's why we're here to help you, is to really provide an option to get rid of your pain so that we don't prevent this vicious cycle. Um, what do we know about the medications that treat diabetic neuropathy? The medication uh, data is there, but the adherence to the medication is very poor. And so many of you might be on or have tried, gabapentin, Lyrica, some of those medications. And so there is data to support there is a benefit of them, but the long-term use of them is in question, right? We also are concerned about the side effects of medications. Gabapentin itself can cause drowsiness in patients. It can cause kidney issues. It can cause weight gain. And so, we have to be mindful that there is certainly a benefit to the medications, but are we looking at the benefit and risk profile of these medications and figuring out, is this the right approach? The other concern with some of the other medications like opioids or antidepressants is they can cause a lot of confusion, a lot of dizziness, a lot of, gastric issues. And so in general, we want to make sure that if we are utilizing the medication, it's beneficial, but what other options we have outside from medications to really help improve your pain. And so I would say a lot of the patients, end up discontinuing gabapentin or Lyrica because it's ineffective or because of side effects. Um, and many are not even taking the medication in the correct way. And so we haven't found the optimal dose of the right treatment. So basically, let's look outside medications to help with this neuropathic pain. Um, you know, Again, applauding you for joining this talk, right? Because you're looking for something else. You're looking for some alternatives to help with your pain, and so you're not alone. Um, you know, I would say patients with on medications, 50% still rated their pain a 7 out of 10. So that means the medications are only working for 30% of the patients. 92% of patients that were on medications for diabetic neuropathy had some sort of side effects, right? And about 10% of patients are not really satisfied with their treatment, right? So, if your primary care doctor, your pain provider, your surgeon, whatever it is not providing you an alternative to medications, we're not doing our job, right? We know there's limitations to medications, and so we should be providing you that extra option for your care. So, this is kind of the main crux of the talk is what are we going to offer? What are some therapeutic options to really provide that chronic pain relief? And I extend this, this discussion is really geared toward neuropathy, neuritis, inflammation, but it can really kind of translate to patients with back pain, translate to patients with failed back surgery, patients that are, have had multiple injections and are still not getting the relief that they're looking for. So this is kind of translate to that as well. And so, every patient on this talk, every patient in my practice is unique, right? And so we're very selective as to who is a good candidate for these types of treatments. And so it's important when talking to myself or one of the nurse practitioners is that we really look at your imaging. We look at your imaging to decide, okay, is this a viable option for you? We look at where is your pain pattern? What have you tried in the past? What medications are you on, right? So everybody's unique. And so not everyone responds to this neurostimulation treatment. And so it's important that that consultation, that discussion happens, on a regular basis, and that we're really dictating what is your pathology and is this going to be viable for you? Um, Neurostimulation has been around for over 50 years. And so this is not a novel therapy. This is a therapy that's been around for many years, and it's evolved. It's improved over the years. The technology has advanced. And so we now have understood what is the best patient for this device. And so I think that's where the technology has been utilized, and that's why we're finding it's really a good option for our diabetic neuropathy patients. Um, More than 30% of patients suffer from chronic pain. Over 50,000 patients undergo this therapy each year, right? So it's really a great option. Many patients that have been on this therapy have utilized not just opioids, but medications in general. I've had patients come off their gabapentins because they're feeling better, come off their Lyrica, not having that weight gain, because their pain has improved with this treatment. And so, what is spinal cord stimulation? So, really, it's a medication-free device. So it's not any medication is delivered, with this device. So if you think about your pain, say you bump your knee, that nerve will travel to your spine to your brain to feel pain, right? So that's the natural progression of how we feel pain. What spinal cord stimulation does is it's stopping those pain signals at the spine level. So it's basically a roadblock in the highway. And so we're stopping that signal so that instead of it traveling to the brain to feel pain, it turns that signal off to reroute the pain fibers so that you feel pain relief. So again, that highway is blocked. We're rerouting the traffic so that it goes to a better route, right? So if you think of it that way, we're rerouting those pain signals so that they feel pain relief. And so that's what we're doing. We're kind of re-triggering the brain, remodulating the brain so that you don't have that continuous pain signaling, that pain fibers. And so, the way it's worked is, there's an implant lead. So there's these little electrode leads that send impulses, and you might have all experienced a TENS unit or a electro stim unit that you put on your back. So similar, those sticky pads are now around your spine, and you have a little battery pack that basically controls the power to those leads. And so each of these devices is controlled by an iPhone. And so you have an iPhone that you can turn the battery on, you can turn the battery off, you can turn the stimulation lead to a certain level, you can turn it off. So it's very customizable. But basically, the component of the therapy includes the leads or the wires, the battery, and then a remote. And so, how do we determine if this therapy works for you, right? So we do what's called a 7-day experience. And so we put this temporary system in your back. We do it under X-ray in our surgery center. And so we do under some IV anesthesia, so kind of some moderate sedation like you would get a colonoscopy. And so what we do is we place these leads under X-ray, and we place them in a specific area that's targeting your pain level. So if you have back pain and leg pain, we're putting it in a specific area in your spine. If you have just foot pain and ankle pain, we're putting it in a specific area in your spine. So it's very, again, targeted to what your pain experience is. And so what we do is we put these little electrode leads in, and then you're going to have a battery that's taped externally on your skin. Okay, so you're going to wear this device for 7 days. There's no stitches, no incision during that 7-day trial period. And so every day during that trial, the company is going to call you. How's your back pain? How's your neuropathy pain? How are you feeling in your legs? How's your sleep? How's your pain with the medications that you're on, right? We don't want you to change anything else aside from seeing if this works. So you have the 7 days to experience it. After 7 days, we just take it out. So we remove it out in our surgery center. And then we have a discussion. We have a consultation to see, okay, what did it do for your back? What did it do for your legs? What did it do for your neuropathy pain? If it's something that you like, that can actually be placed underneath the skin, and we'll talk about that treatment. But about 80 to 90% of our patients that go through that trial experience go forward with the implant, go forward with the surgery. And so why is that number so high in our practice? That is because we've been doing it a while. We've been doing this trial. We know how to do the procedure well. But most importantly is we're picking the right patients for this therapy. So having the right mindset, having the right indications for this therapy allows for this therapy to work and patients to do well. What we're looking for is 50% relief, right? So there's injury, there's inflammation that happens. So we're not expected to get 100% relief. But if we can get 50% relief, get you feeling good, get you more comfortable with your current medications, that is a positive result. And that is the effect we're looking for. And so once you have that trial, the next step is to, think about how to get this implant in. And so the way we do that is we basically do the same procedure, accessing the leads, putting the leads in, and then just like a pacemaker, we create a little pocket in your back, and then we put the little battery in. The nice thing about these batteries is they're literally the size of, if you fold dollar bill in half. It's about the size, of a dollar bill, right? It's the size of a little pacemaker or a little cookie. It's very small. It slips right underneath the skin. These batteries can last you 7 to 10 years. They can last a long time. These batteries, you don't have to worry about charging. So you leave it in there, you set it, you forget it. So it's really, you know, uh, a device that you don't have to worry about on a regular basis. It's actually working continuously without you doing anything. And so everything is controlled by the remote. The pharmaceutical rep can come in and program it. They can meet you at your house, at the clinic. They can really help you optimize the therapy that you need. Um, again, these batteries last 10 plus years. And so, when we talk about who's the right candidate for this therapy, it's the patients that have, nerve issues, nerve in the leg, nerve in the feet, nerve from the hip down. It's affecting your daily life, right? I don't think you'd be on this discussion if you weren't experiencing some sort of discomfort that your current care is not optimizing, right? Maybe you're on medications that's not controlling your pain. This is something that we can consider for your pain. And so, second set of questions that you should ask yourself, do you think you have diabetic neuropathy, right? Are you experiencing some of these symptoms that you have in your feet and your legs? Second question, have you heard about spinal cord stimulation, right? Have you heard about this therapy? And then, third question is, what else can we answer about how this therapy, or do you think this therapy might fit what condition you're having? And so, again, we talked about this in the implant stage. After you go through that trial period, that 7-day trial period, meeting with us, meeting with me, meeting with your nurse practitioner to discuss, okay, what was the benefit, what sort of effects you had, and then talk about the surgical implant. And the surgical implant is done by myself. We do it as an outpatient basis. It's about a 45-minute procedure where you get some anesthesia. But again, it's something that we expect our patients to keep lifelong. We want this therapy to work for you. We want this therapy to control your pain. We want you to be as invested in this device as, we are in putting it in. And so, I tell my patients, once we put it in, it's something I want to keep with you forever. Now, it is something that can come out, right? So we've had scenarios where maybe the patient has not gotten the best result after, a couple years, 10 years, and they want the device out. We can take it out. But that is very rare, or the patient needs back surgery now for whatever reason. That device can be taken out if it's an emergency type surgery situation. So again, it rarely happens, but certainly it is something that can be removed if it needs to be removed. And so, I encourage all you, to discuss with me in the office, discuss with your pain doctor about, what you learned today, what questions you have, whether this is a therapy that at least you want to go through that 7-day trial, right? What is the downside of that trial? It's a procedure, it's like an injection, so the same risk of that. But I tell my patients, I tell you that it's 7 days of experience, right? I won't be able to know if this is going to work for you unless you try, unless it's something that you've experienced for yourself to see, hey, what did it do for you and your pain that you're experiencing? And so, we talked about here is not just pain control, but I want to know, how's your walking, how's your ability to stand, and then sleep. Sleep is an important, like we looked at that pain cycle, sleep is a big component of your pain. And so sleep deprivation can, make pain worse. And so a lot of my patients, going through this is their pain is better, but they've probably slept, the best they have in their life, right? And so that is something that is a big component of why we do this therapy. Um, and then, this is again just talking about the implanted system. Again, it's done as an outpatient basis under some IV anesthesia. And so, this is very, we're jumping into the stage of technology and, artificial intelligence. And so, it's really advanced technology that we can offer you. It's advanced technology that is smart and knows your body. It can really, conform to what your needs are. And like I said, every patient is different. And so, my therapy versus, uh, uh, you know, um, another nurse practitioner, Grace Hassan's therapy or Dr. Smith's therapy, it would be all different, right? It's different. It's tailored to what you're experiencing and what your pain pattern is. And so, with that, I just wanted to kind of end the discussion here, the specific talk, but really just open it to any sort of questions that everyone might have. Let me just get you. Okay. And if you have any questions, you can unmute yourself and then ask a question, or you can submit something in the chat box as well.
What's the cost for both stages?
Yeah, so great question. So, we go through insurance coverage for this device, and so typically Medicare, commercial insurance, and some Medicaid plans do cover the trial and the implant fully. So typically, what we do is we again identify if you're a candidate for it, and we submit it to insurance for approval. Because this is a device, the insurance companies do require a psychiatric consult. So the purpose of that is because it's a device that you control. They want to make sure you're able to do that. And so what we do is we send you for a virtual consult that you can do from home. It's a one-time visit, psychiatric consult. And so once we get that, then we send it to insurance and to get it approved. So, again, unless you have a deductible plan or an out-of-pocket expense, usually this is 100% covered by insurances because it's been around for many years. Good question.
Is if you have issues in your low back, issues in your hip, issues in your buttocks, and then like a neuropathy pain in your foot, can it control more than one problem?
Yes, very good question. And so again, that goes to where we place it. So for example, if I have patients that have the back symptoms, buttock symptoms down both legs down to the feet. And so this device can be placed in a certain area of the back to cover that whole area, that whole segment. And so yes, to answer your question, absolutely. So if you have just foot pain, for example, right? You don't have back pain, you just have pain from your knees down. I can place it in a certain area to cover just that segment. And so it can be covered, typically I tell my patients back all the way down is what we can target. Now, say you have neck issues, right? Say you have neck pain and pain down the arm, and you have also low back pain. It can target the neck also, but we just have to place two separate systems. So the low back spinal cord stimulator will not treat the neck pain. It'll treat the low back and below. Does that kind of make sense?
Yeah. I would be looking at the low back and below anyways.
Yes, exactly. Yeah. So it would kind of treat that whole area. A question that came on the chat is it iPhone only or Android? You get the phone. So they give you an actual iPhone. And so you might have an Android that you use for your personal use, or an iPhone that you use for personal use, but they give you a separate iPhone that you can use for phone calls, but you can use it for that technology to turn the stimulator on. And then another question that came on the message chat is what if you had a spinal cord stroke? Would it affect the treatment? So no. So actually, when you have spinal cord injury or stroke, you have nerve type pain, nerve type symptoms. So this is the same. This is actually a treatment for nerve pain related to a stroke or related to a spinal cord injury. And so it does not affect the way we place it. It does not affect the way we actually target the nerves. This would be a viable therapy for that type of condition also. Great questions.
What's the down? I mean, you're not telling us any downside. What can happen? Could it cause an injury while they're inserting it? What would be the most negative part to not doing this?
Yes. So another good question. So it is a procedure, right? So with any procedure, there's always risks. The main risks are infection and bleeding. And so we do our job of making sure, you stop the blood thinners before you have the procedure. We do the procedure sterilely. So it's done in a sterile environment. We do give you antibiotics, after the procedure to prevent any sort of skin infection. So those are the two major side effects. The second is, spine injury, right? We use this we do it under X-ray. So we make sure we're targeting the right nerves. We make sure we're placing it in the right place. And so, rarely does this, it's behind the spinal cord. So rarely does it cause any spinal cord injury. But again, that's why we use X-ray. That's why we make sure we're in the right place while we're doing the procedure itself to have all those safety measures. And so those are the side effects. Those are the concerns during the procedure. The negative is that, it might not be a therapy that works for you, right? So I said, 80% of the time the patients do great with this device as a trial. They move forward with the implant, but there's a subset of patients, 20%, that maybe it just didn't work well for them, right? And so the negative is that maybe the therapy just didn't work for you. And so, I think those are really the most common things we encounter. The device is made to last, forever. And so, with that being said, is I, choose the patients to select the patients that really are interested in this therapy and want this as, a lifelong therapy for them. Good question. Does anyone have any other questions, that I can answer?
I'll ask one more.
Yeah.
In the trial stage, when you have the not, when you're wearing a battery and everything, are you limited to things that you can you shower? Can you do a normal life while you're wearing the trial?
Yeah, so typically during the trial, because it's external, the battery's placed on the skin. We don't recommend, doing hot baths or soaking in a shower or anything like that. We do recommend just kind of either sponge baths or kind of doing that type of shower. The trial is anywhere from 3 days to 7 day experience, right? So 7 day is the max. We can remove it as short as 3 days. So 3 days of doing that kind of sponge bath, things like that, is okay. As far as activity, I usually recommend my patients to do everything normally, right? We don't want you go ahead and, you might be feeling better, but not go ahead and lifting a ton of weight or doing anything excessive, but normal day to day, walking on a treadmill, going to the grocery store, doing those things activity wise is what I actually want you to do because I want to know with this device in, are you feeling much better? Um, so there's not real major hard and fast restrictions other than, doing something that you normally wouldn't do. As far as work is concerned, I do have patients during the trial stage go to work because we also want to know with this device in is, how's your work? Are you able to work a little bit better? Just knowing what the work limitations are, but certainly there's not a lot of restrictions during the trial stage.
Talked a lot about the neuropathic pain. Does this have any benefit for phantom limb pain?
Yes. Yeah. So, I think that goes hand in hand with nerve type pain. So it is a device that is approved for phantom limb pain. That was actually probably one of the first indications that it was used for, because, when you have an amputation, you have, injury to the nerve structure. And so, absolutely. So depending where your amputation is or depending where the phantom pain is, we would target the specific nerves related to that, to controlling that pain. And so, that's something that definitely it's approved for.
Thank you.
Yeah. Are there any more questions, about the trial period, you know, um, about the device itself, about the pathology? You guys really asked some great questions. So, I'm very happy to hear, the interest and the questions among the group.
we would set up an appointment with you to go over all the ins and outs before, and then you would determine if and when you would do the trial.
Yes, absolutely. So yes, so consultation with myself, consultation with one of our nurse practitioners, is going to be very important because what we want to do at that time is look at your imaging, look at what treatments that you've had, understand what is your pain pattern. And so, like I said, I think where we see this device being used and where we see actually the evidence to support it is really, um, I would say four specific areas. So, number one being any nerve type pain. So that nerve type pain can be from previous surgery. That can be from diabetic neuropathy, right? The second place where I see this a benefit is you've tried injections, you've tried other treatments, and you're not interested in surgery, right? Spinal cord stimulation can work with your medications to really help relieve your pain. So that in between stage of you tried injections, you're not ready for surgery. This is a good therapy. Third, where I see this really beneficial is just like the gentleman mentioned, that phantom limb pain, that pain after you've had knee surgery, if you've had ankle surgery, right? That chronic pain that you're dealing after those treatments, this is where that kind of is geared for. And then the last segment is patients that have neck pain and kind of pain in the extremities. But hopefully, having one of those indications in mind, talking to your provider about, is this going to be viable for me, if I fall on one of those conditions, is something that we should discuss.
So can I ask a question for Robert? He wants to know, so if he wants this, procedure done, does he actually let Dr. Z know, Sakari know that this is what he wants to do?
Yes. Yeah. So, absolutely. Talk to Dr. Zakari and let him know. And what we're going to do is everyone that was invited to the talk or everyone that has been on the discussion this afternoon,
Yes, sir.
we will let your provider know that you engaged in the call and to have that as a talking point during your next consultation.
Yes,
And so, yeah, absolutely. Well, we wanted to use this as just a way to answer questions, but then kind of let the providers talk in more detail with you personally.
yes, sir.
Perfect.
Mhm.
Good. Are there any other questions that I can answer for anyone?
Question got answered.
Dr. Mehta, do you take patients without referrals? I have a very good friend that sees the same pain management doctor that referred me to you, and she is going through terrible, terrible back pain and has gone through the epidurals. And I think she would be like an ideal candidate just based on what you're saying. Would this be someone that can call the office and get an appointment set up? Or does she
Yeah.
have to have a referral?
Yes, yeah, absolutely. So, yeah, you can, yeah, she can call the office and ask for a referral. And typically, we do need a primary care doctor referral, but our teams can facilitate that. They can just request it on her behalf.
Okay.
But yeah, absolutely. If you think she's interested, just have her call, let her know that she talked with Dr. Mehta and that she would like to be potentially seen in the office.
Okay. Great. Thank you.
Perfect. Well, with that, I think we'll end the discussion. Again, really want to congratulate everyone that joined the talk today. You're really looking for something that can benefit you, and so hopefully, um, this talk was a starting point to discuss, other options aside from medications to help with your pain. The providers are all here to support you. DOC is here to support you in your pain care. So, don't hesitate to reach out to us and ask more questions. We're happy to help and hopefully you guys can enjoy that nice 56 degree weather we have outside today. So take advantage of that weather. All right, thank you all. Bye bye.